Hello, my name is Lola Arushola. I'm one of the final year medical students here at St. George's, and I'm particularly interested in obstetrics and gynecology as a career. I'm sitting here with Miss Suruchi Pandey, and she is one of our obstetrics and gynecology consultants, and she's also the lead for endometriosis and the lead for undergraduate teaching in obs and gynae as well. Welcome.
Hi Lola. So today we are going to talk about endometriosis.
Yes.
Wonderful. Fire away.
All right, so the first question I had is, can you tell me a bit just what is endometriosis?
So it's one of the most enigmatic conditions in gynecology. This picture would explain a bit. So this is a hand-drawn picture, please excuse my drawing, but this is supposed to be the uterus, and this is the lining of the womb. So during a menstrual cycle, this lining builds up, and then when women menstruate, the blood comes out.
Yes.
And what is shed is the lining, which consists of endometrial glands, which produce all the bleeding that a woman has.
Yes.
So if these endometrial glands are present in places other than the lining of the womb, that is in the pelvis, in the ovaries, in sometimes even behind the uterus, in the bowel or in the bladder, or it can be anywhere in the body. So when the endometrial glands are present anywhere else in the body, then that condition is called endometriosis.
Okay.
It's a chronic condition, it's a chronic inflammatory condition, and it is estrogen dependent. So it is a condition that affects women of the reproductive age group.
Okay. All right. And when it comes to endometriosis, why do some women develop it?
Well, we don't know. There are various things that have been postulated. So in the earlier times, people thought it was because the menstrual blood, instead of coming out, it was going via the tubes to the rest of the pelvis.
Okay.
That still remains one of the hypotheses, but it does not explain endometriosis in the lungs. Sometimes it can be present in the umbilicus, sometimes it can be present anywhere in the body. So that hypothesis does not explain most of the presentations of endometriosis. So then we have to think, what else? What we are finding more and more is there is a genetic link. If you have a first degree relative who has had gynecological problems, pelvic pain, then you are more likely to develop. And this we have found in at least 50% of the cases.
Okay.
So if there is some genetic predisposition, and then you are subjected to high estrogen levels due to whatever reasons, then that promotes the changes. That is the endometrial glands from causing the bleeding in places other than the uterus.
I see. Okay. And you mentioned about estrogen. If you've been exposed to a lot of estrogen, can you expand a bit more about that?
So that can happen in women who have had an early menarche.
Okay.
In nulliparous women in whom you have had no pregnancies or delayed pregnancies. But sometimes, coming to the next point, that endometriosis itself is present in up to 50% of the women who suffer from difficulty conceiving, or what we call subfertility.
I see. Okay. Oh, thank you for explaining that. And how would somebody know if they have endometriosis?
Okay. So let me show you some slides to explain. So endometriosis can be in the pelvis or anywhere else in the body.
Yeah.
When it is in the pelvis, we call it pelvic endometriosis. So most commonly when we find pelvic endometriosis, it is present behind the uterus or in the side walls.
Okay.
And these are basically deposits of endometrial glands which are present there. So initially they may look like black spots. So if you can see this picture, you can see these black spots behind the uterus. That basically is endometriosis. So because endometrial glands, wherever they are, they will bleed. And blood can cause inflammation. And inflammation leads to scarring. So that is how the various symptoms present. So if there is bleeding and scarring behind the uterus, just behind the uterus, then the woman may present with what we call dyspareunia, which is painful intercourse. Then if there is endometriosis, it can cause painful periods, which we call cyclical pain, that is pain during periods. If it is very close to the bowel, then see if the poo is coming out, especially during menstruation, women say that it's very painful to pass stools. And if this lining of the womb is present in the muscle layer of the uterus. So this muscle layer becomes, during the periods there's a lot of cramping, discomfort, and that is condition is called adenomyosis, and that can be associated with heavy menstrual bleeding.
I see.
So all of this is pelvic endometriosis, but if we go to extra pelvic endometriosis, then women can experience shoulder tip pain, cyclical chest pain. Sometimes women who have had cesarean sections, they can have scars and nodules because of deposition of endometrial glands after cesarean section. So what it presents is lumps on that side where there's cyclical pain, and they are very, very uncomfortable during their periods. So and then sometimes even in women who have had no previous surgery, you find what is called umbilical endometriosis. So there is a small nodule in the umbilicus, and every time a woman has a period, there is bleeding from the umbilicus. So that's what we call umbilical endometriosis.
I see.
But fortunately, extra pelvic endometriosis is very rare.
Okay.
But pelvic endometriosis can be present in up to, the general prevalence of endometriosis is 10% of the population, which is like 190 million adolescent women and reproductive age group women, so which is quite a sizable population.
Okay. All right. And so if a woman does believe she has these symptoms, what can she do?
So coming to a very important point, because sometimes women feel that they are supposed to suffer and that periods are supposed to be painful. But if a woman is having pain, or a young girl is having pain so much so that they are having to take time off, and if they're worried about the period for those few days when they're going to have a period, then they need to consult their GP and tell them about these symptoms. A large part of it is education of the GPs as well, because somehow the GPs till now have not been very aware of these symptoms. So they have managed, if the scan is normal, they do get a scan done, but if the scan is normal, they assume everything is normal, which is not the case with endometriosis. Sometimes I go in and do a laparoscopy on a woman whose scan has been reported as normal and find very severe endometriosis, things very stuck to each other, and then peritoneal endometriosis, which is like black deposits, they can't be seen on scan.
Okay.
So that is why, of course, the first step for a woman is to go and see the GP. They would talk about the options of management, they would organize a scan. But even if the scan is normal and a woman is persisting with those symptoms, then she needs to be referred to the hospital with a consideration for doing what we call a laparoscopy, when we put a camera through the belly button and have a look inside, and only then we can completely rule out the disease.
I see. So just to be clear, is it because of what you've just explained that it can take between 2 to 10 years for a woman to be diagnosed with endometriosis?
So unfortunately, even now, I see women every Monday is my endometriosis clinic day. You have attended those clinics, and it's actually a very depressing day, because even now, even after so much education and awareness about endometriosis, I regularly see women, and their story that they give me is they saw their GP and they were having period pains, and the scan came back normal, and they were just told to take painkillers and maybe some tranexamic acid to reduce the bleeding, and so they kept on having pain, thinking that, and some of them were even told that it's in their head, and it led them to believe that they're just making up the pain. And then the symptoms became worse, and a repeat scan sometimes shows that they have got big cysts, and that is hugely depressing for women. And I recently had a patient who was told by the GP that she had fibroids and adenomyosis and endometriosis, so very severe disease, and she was told by the GP to lose weight.
Oh gosh, okay.
So I think there is something going wrong in the society, where I feel women are not being heard. And I would have thought that if it were a disease that was more prevalent in men, and maybe we would have had more awareness and more things would have been done about it by now, because it is really shocking, the stories that we hear about endometriosis. And I think awareness is a large part of it, But the main thing is listening to women. You know, if somebody's coming to you every other month saying that, look, I'm uncomfortable, something needs to be done about it.
Absolutely. Okay. And for endometriosis as well, what are the options for treatment?
That's a good question. So the first thing is to understand it's a chronic disease. It's something like diabetes, hypertension. So there's no treatment like that is going to be one-off and is going to cure women completely.
Okay.
But there are various things, and the treatment has to be tailored to the needs of the woman. So if a woman were to come to you, you have to find out what she wants. Does she want to have children? Does she want her pain to be managed? That's the first question. If it is the management of pain, does she want medication or does she want surgery? So it has to be, you have to work with the woman, and also understand that it's not just endometriosis, it's the whole spectrum of things that come with it. So if a woman has endometriosis, it affects her family life. I mean, half a month she will be feeling uncomfortable. She will not be able to have sex with the partner. So there's a lot of psychological issues. And also, there may be ambitious women who might want to carry on with their work, so they're pushing themselves harder and still not succeeding. So a lot of frustration and anger amongst these women that, we are trying our level best, but we are not, nobody's listening to us, nobody's doing. So it's a very complex condition. So endometriosis care needs to be very holistic in the sense that it's not just giving medicines. It is listening to the woman. How can you support them socially? How can you help them overcome the anxiety and depression? And what portal do they have? Somebody to talk to, somebody to communicate, what support groups are there, what networks you can provide them so that they can talk to each other, and all of that will help. But somehow services probably all over the country are not that organized. I think it's getting better and better, but it needs to be much better, because what we don't understand is that this disease affects women of the reproductive age group, so that when they're in the prime of their life, and so many days are just sucked out of their life because of this disease. There's a lot of emphasis on cancer, and I have full sympathy for women with cancer, but at least the world has sympathy if you have cancer. But women with endometriosis, they are suffering, and on the outside they look all right. So, and the world thinks, why can't they just get on with their job? So that perception needs to change, and there has to be more sympathy and more recognition for this very complex condition, and how the healthcare system should manage it. So it definitely is an area where we need more manpower, more resources, and more holistic care.
Absolutely. Okay, and I think something I wanted to touch on as well is the link between endometriosis and fertility. How does it affect women getting pregnant?
So again, very strange, because sometimes I find women who have severe endometriosis and you just diagnose it when they're having a cesarean section or something. So they fall pregnant and they didn't even know that they have severe endometriosis. And sometimes women who have just a spot of endometriosis, they would find it difficult to conceive. And as I said, up to 50% of women who find it difficult to conceive, they can have endometriosis. So there are various ways by which endometriosis can affect fertility. It can make the environment inside the uterus more inflammatory, so implantation doesn't take place. We talked about things getting stuck and adhesions. These adhesions can cause tubal damage. So women are more at the risk of ectopic pregnancy or not conceiving at all because the tube's being blocked. Then if an endometrioma is present in the ovary, that is endometriosis of the ovary, again there is inflammation, there is production of free iron species, and all of this cause a decrease in ovarian reserve and also the quality of eggs. That is, the eggs that are present inside the ovary, they're not as good quality as somebody else of a similar age group.
I see. Okay. And I guess my final not question per se, but if you could just give like a parting comment about endometriosis and the future, and what women can hope for.
So I think the future is bright because more and more, I've seen a lot of change in the last 10 years in endometriosis care. But we do need this mobilization of resources. But I think that the greatest sort of new developments in gynecology are going to come in endometriosis. What I think is, in future we are going to find out what are the genes responsible for this disease, and then be able to offer some people a screening. So women who have a family history, if we can offer them some kind of screening and start them on some kind of preventative hormonal treatment, then it may not get as bad.
Okay.
So I am hoping that will be the future, because as I said to you, the surgery, medicines and all of these, they are different options of treatment, but sometimes it's very frustrating because somebody who's trying to conceive, they can't have medication because it stops them from conceiving.
Yes.
And then the medication, especially the progestrogens that you give to women, they have got a lot of side effects. The women report their acne, a little bit of weight gain, low mood. So it's not like the perfect option.
Yes.
And even with surgery, there is a recurrence rate up to 50% over 5 years. So women end up needing repeated surgeries. So what is going to happen in the next 10 years is that a lot of resources will go in this direction, and we will have more knowledge about the pathophysiology of the condition, why it happens and how we can stop it at an early stage. So I would say, in the next 15 years, when you are an established consultant, you will see all of this happening, and maybe I will come and interview you, and then you can tell me about those developments.
Well, thank you very much, Ms. Pandey. Very illuminating.
Thank you.
Sorry, that's fine. It's